We'll start our session now on comparative effectiveness research.
Later about.
And we will start with my introducing our moderator, and welcome to Dan Leonard. Dan is the president and CEO of the National Pharmaceutical Council and will be our moderator today. And that council basically sponsors and participates in research on the appropriate uses of pharmaceuticals and the clinical and economic value of pharmaceutical innovations. NPC's research contributes to the scientific foundation for informed decisions about health access, coverage, and appropriate use and value. And so Dan will introduce the topic and then introduce the panelists and moderate our session.
Excellent. Thank you, Fran Marie. Thank you, everybody, and looking forward to this session on what's been a very hot healthcare topic through the course of this year, and that is comparative effectiveness research. And it's a very important element of the much larger healthcare debate that's going on in Washington right as we speak, across the street and across the street the other direction. It is in some form, different varying forms, included in all of the legislative proposals that have been offered on the Hill. So they'll be kind of vetting those issues over the next days and weeks and trying to come to some consensus around comparative effectiveness as they go through the legislative process. It was also, as most of you may know, part of the stimulus legislation earlier in this year, where $1.1 billion was appropriated for comparative effectiveness research. It's being positioned in the policy realm as a means to improve quality of care and decision-making between the provider and the patient, while at the same time reducing unnecessary healthcare costs. Now, very noble goals, both improving quality while bringing down costs. That's where we need to go in this system. But as in most things, it's not always quite as easy as that. So we're going to focus today, the discussion today, on comparative effectiveness, but with the patient at the center of the discussion. How can we work toward these noble goals of improving quality and reducing cost, but while at the same time making sure that the specific individual patient who's sitting in that examination room with that physician is being taken care of as an individual? And how is that going to work vis-a-vis these types of research programs that are being talked about, which look at very large populations and how medicines or treatments or specific surgeries even, how they impact large populations? How do we preserve the intimacy of that patient and doctor relationship? So we've got a terrific panel to talk about this very issue, and I'm going to briefly do some biographical background on all of our panelists, and then we'll jump right into the topic. Dr. Robert Honigberg is a healthcare executive with broad experience in the fields of medical devices, diagnostics, and pharmaceuticals. His area of expertise focuses on technology innovation, clinical and economic trials, and health policy. Currently, Dr. Honigberg is a member of the steering committee for the Aspen Health Stewardship Project. He previously served as the chief medical officer for GE Healthcare and in a variety of senior positions in the medical device and pharmaceutical industries. Phyllis Greenberger is the president and CEO of the Society of Women's Health Research, an organization working to improve the health of all women through research, education, and advocacy. She has received numerous awards for her efforts on women's health, strengthening federal support for women's initiatives, and improving women's access to clinical trials. Ms. Greenberger also is the co-editor of the Savvy Woman Patient, How and Why Your Sex Impacts Your Health, a resource guide that details differences between women and men across major health areas. Dan Smith is president of the American Cancer Society Cancer Action Network, which is the nonprofit, nonpartisan advocacy affiliate of the American Cancer Society. As president, he is responsible for the overall development and execution of legislative, political, and grassroots strategies at the local, state, and federal levels to advance the Society's life-saving mission. Mr. Smith joined the Society in 2000 as National Vice President for Federal and State Government Relations and was named to his current position in 2006. He also founded and leads One Voice Against Cancer, a coalition of more than 40 cancer-related organizations. And finally, at the end of the table, Marc Boutin, who is the Executive Vice President and Chief Operating Officer of the National Health Council. Marc previously served as the Executive Vice President and prior to that as Vice President of Policy, Development, and Advocacy. In addition to overseeing the financial management and operations of the Council, Mr. Boutin builds consensus among member patient advocacy organizations, enabling them to speak with a united voice on policy initiatives resulting in legislation and regulations that address the collective needs of patients and their family caregivers. So, to kick things off, I'll paraphrase the President to start and then pose a question. So the President has said on more than one occasion in his characterization about comparative effectiveness research, quote, "If there's a blue pill and a red pill, and the blue pill is half the price of the red pill and works just as well, why not pay half the price for the thing that's going to make you well?" Pretty simple, right? Just find out what works best in a certain disease area and push that approach, and then get rid of all of the things that don't work as well. That's the very basic concept behind comparative effectiveness research. So I'll start with you, Dr. Honigberg. Is it really that simple? Or is there more to comparative effectiveness where the needs of the individual patient come into play?
All right. Do you want us to jump right into the question, or start with an opening statement?
Give us a little background from your perspective, but then that's kind of the area
that's
we
where
want to drill down
we'll
into.
Go to. Yeah. Very good. Well, I'm here to represent the industry, given my experience as an executive both in pharmaceutical, device, and diagnostic. I am currently independent, which I think is important for this panel. And I'm going to start with personalized healthcare and then kind of get into the population statistics trials, comparative effectiveness aspect. I do think industry has a very good opportunity to further the personalization of medical care. And when you look at the clinical and health economic models and data out there, there is some real validity to a prediction and prevention type of model that uses specific genetic markers and biomarkers, the benefits of early detection and diagnosis that allows more effective, targeted, more minimally invasive treatment, has real merit, and the benefit of more accurate diagnostics that reduce false positives and reduce the number of unnecessary biopsies. All of these enable personalization. The key question that I'd like to just bring up in the opening statement is whether the industry business models and practices will allow it. And also whether the regulatory and payer requirements will enable personalized health care. A key part of this debate, which really brings us to cost effectiveness or comparative effectiveness, has been a focus on the utility of population statistics and the ability to generalize results of randomized controlled trials to diverse populations in a variety of clinical settings. And when you look at the pharmaceutical industry, certainly those sponsors do their best to optimize patient selection within a randomized clinical trial. In my opinion, the pharmacogenomic model of development has been underutilized. And this is the model where you have a specific marker that will target responders. You've already heard someone present the HER2/neu receptor as a great example of that, where you maximize responders and minimize non-responders. And the industry may be reluctant to let go of an old business model. I believe that pharmacogenomic model can allow a building of a market, kind of one patient subgroup at a time, really going after patients that have a higher probability of response. It's viable, that model, and it will also minimize the potential for off-label abuse or usage. One of the most important areas for this strategy is in oncology, where we have an opportunity to increase response rates from averages of 20% upwards of 80%. And this is really a matter of how do you minimize avoidable toxicity, and really gets into patient safety issues. I also think that gene signatures that can really get into tumor biology and understand which tumors are more aggressive will also lend to better response rates and better targeting of patients. Now, just switching gears to medical device, I think medical devices present their own set of unique issues. And I actually believe that comparative effectiveness research is more important for medical devices than pharmaceutical. I say this for the following reasons. First, the majority of non-implantable devices don't require clinical data to get regulatory approval. It follows a 510K clearance model. And as a result, the majority of the device industry does not have an infrastructure for outcomes trials, nor do they put a high priority on generating clinical data after a product comes to market. Also, the majority of devices are used within procedures or techniques that involve a learning curve, and there can be a wide variation in outcomes. So when you're trying to generalize these kinds of randomized controlled trials, or really any prospective trial for these kinds of devices, it can be limited because usually these trials, they select expert sites that have undergone very rigorous training. In some ways, it's kind of like stacking the deck, and it's difficult to duplicate results at a more average institution. So to me, I think the real opportunity is in innovative prospective trial design. I think this can be part of comparative effectiveness. It's just not randomized controlled trials that include a diversity of sites and a diversity of patients. I really like registries, particularly ones that can tap into electronic medical record data as well as wireless data collected through wireless devices. So we can understand how patients are selected in the real world, so we can understand why there are variations in outcomes in the real world, and also determine the most responsive subpopulations if that hasn't been done up front in the development. Also, registries can be useful in documenting and understanding the phenomenon and the reasons for overutilization and potential misusage of new technology. So I'll end with your question, Dan, and it may be a little bit more device-oriented. I think payers, because there is a model within the device industry of multi-generational product plans. Every year there is a new generation of a product, and it's not clear what additional medical benefit it provides. So usually these technologies, they have a price premium. And from a payer standpoint, the payer would want to see superiority when you compare two technologies to really back the price premium. If it's equal price or less, they'd want to see at least an equivalent type of technology. So, I think what payers see, particularly in the technology world, is a layering effect. It's very difficult. You don't see a lot of obsoleting of old technologies. In many ways, they kind of pile up on top of each other, and then all of the technologies are used. And it's unclear which patients benefit the most. That's the way I'll end. Thank you.
Phyllis, then Dan.
Okay, thank you. Well, I think I'd like to start, if I remember correctly, the answer to the President's question, and my answer is no and no. First of all, one pill's not going to be appropriate for everybody. And number two, if you just pick the cheapest pill, then you kill innovation and research. So I'll start there. Let me just tell you who I represent. The Society for Women's Health Research was formed in 1990 to address inequities in women's health due to the fact that women and minorities were not routinely included in clinical trials. And while it's clear that we've made a lot of progress, and certainly women are now required to be in clinical trials by laws changed at the NIH and the FDA, which we worked on, although still there are not sufficient numbers in many trials, and of course in minorities we're still lacking. But there's very little sex analysis, and the whole point of including women and minorities in these trials is to analyze for differences, and we're not making very much progress there. We know from our scientists and our researchers and the work that we've done that there are a combination of genetic, hormonal, physiological, and environmental factors that affect differences between men and women in terms of diseases. We know that diseases such as cancer, obesity, cardiovascular disease, autoimmune, depression, all exhibit sex differences in susceptibility, prevalence, time of onset, and severity. And we know that there are sex-based differences in devices and common medications, such as antibiotics, antihistamines, some cardiovascular drugs, antidepressants. And we don't necessarily know why that is yet. We know that it may have to do with varying rates of metabolizing, or it may have to do with the levels of liver enzymes in the body, and we're still looking at that. In fact, we established a scientific organization almost 3 years ago of research of basic and clinical research scientists looking into these genetic and hormonal and basic research differences, and we actually know more about what we don't know than we know about what we do know. And the research is continuing. So our concerns, and I must say, starting looking at the beginning of comparative research and the initial discussions, which of course were sort of interchanged with cost effectiveness, which everybody was concerned about, needless to say, that there's been some progress. A number of years ago, I can't even remember whether it was, I guess it was during the primaries, I'm not really sure. It was at least a year or 2 years ago. A women's health group that I belonged to invited a member of Congress to speak, and he was talking about health care reform. This was on the House side, and he was talking about comparative effectiveness. And after his presentation, I went over to him and I said, Congressman, we really don't have very much information on sex differences because women have not been included in trials. So how will they design comparative effectiveness studies so that we can get that information? He said, well, do we have that information now? And I said, no, I just said that we haven't had women included. He said, well, so we won't use it. I was sort of, okay, we don't have that information. So we're a little anxious at that point about it. Now, I think that there certainly has been, through a lot of efforts by the different patient groups, the cancer organizations, our group, of course, as well as the device and the pharmaceutical industry, to educate Congress about the fact that this is not simple and that comparative effectiveness, frankly, as I think you all know, the devil's in the details. How are they going to do it? If they're going to use epidemiological studies, if they're going to do literature searches, then we're not there. And a lot of us aren't there. Different subgroups aren't there. It's hard to imagine that they're going to do randomized clinical trials on every therapy and every device. I can't imagine that's going to happen. So the question is what kind of information they're going to use and how they're going to use it. So we obviously, from our perspective, comparative effectiveness has to study men and women and analyze fully any sex-based differences in disease prevalence, treatment, and procedures. And as part of that, and this is much more recent, actually in the last few days, there's conversations about where this is going to be housed. And as was mentioned earlier, originally in the stimulus package, there was $1.1 billion for ARC. We firmly believe that it should not be only an ARC. ARC is part of it, that's fine. But we need different expertise across all the health agencies. We'd like to see NIH involved and the FDA involved, as well as ARC. We also believe that patients have to be included, that there has to be a patient voice, and it needs to be patient-centered care. It cannot be physicians and scientists and researchers that we need to have a voice as well. One of the things that disturbed us most recently, I don't know how many of you are familiar with the Institute of Medicine report. They were asked by Congress to gather a group of experts together to look at those areas where comparative effectiveness research ought to be done. We have written a letter to them. We have not gotten a response yet. While they did acknowledge that subgroups were important, demographic, ethnic, physiological, and genetic, their definition of women's health was obstetric and gynecology. And we thought that we had long been over that. So we still have grave concerns about how we believe, obviously, that sex differences must be incorporated throughout all research and all conditions, whether it's depression, cardiovascular disease, autoimmune disease, not just obstetrical and gynecological health. And lastly, we're concerned about research, which I mentioned earlier. Because women were not routinely included in clinical trials, and because we don't have the answers to a lot of the questions that we need to have the answers to, we need to continue research. We need to continue to have innovation. And our concern is depending upon the way comparative effectiveness is used, that it could have a detrimental effect on innovation. And we can't afford to have that. The other thing, and I guess this is last, I had a conversation with a cardiologist from the Mayo Clinic not too long ago, and this really surprised me. She was concerned about how comparative effectiveness was going to exist with pay for performance. And since we know, in our case, women, and this is true for some minorities also, where there are less positive or less good outcomes in certain conditions for certain populations, whether that was going to have an effect on insurance and also what patients, physicians would choose to treat if they could anticipate based on past performance that they would have worse outcomes. So I guess I should have started by saying that on the face of it, we're all for comparative effectiveness. We all want to know what works best, when, for whom. And it makes sense, obviously, but the question is how that's going to be done, how the research is going to be done, how it's going to be analyzed. Thank you.
Thank you, Phyllis. And Dan, from the perspective of the individuals that you represent in cancer.
Yeah, I think that basically we do not fear comparative effectiveness research. We actually have been doing it in the cancer community for many, many years in lots of different ways. But it does need to be done in the right way. It needs to be transparent and open, and people need to understand the limitations of it from the beginning. I believe that comparative effectiveness research is a foundational element of evidence-based medicine, and we need to move to a system where the evidence is actually driving the medicine, but we don't have perfect evidence. And I'm not a scientist. I'm a political guy who's got a law degree, but I've been around the scientific community a lot for the last 10 years of my job. And the more you're around it, the more you realize that there's so many subtleties to any kind of study or research, and you need to actually take into account those subtleties as you're looking at the various proposals that are out there, or the various, kind of findings that come out. Cancer, as many of you know, is actually more than 200 different diseases. Cancer is not a single disease. One of the things that we struggle with sometimes when we represent the Cancer Society is to get people to understand that, we're not probably going to have a silver bullet in solving the cancer problem, and we're going to make slow but steady progress, which is why evidence-based medicine is so important. And I think you need to look at this from a broader perspective. The other thing that happens with this issue is a lot of people just focus right on drugs. So the president's comment is, well, let's look at two different pills. And there are times when you want to look at two different pills and say one's better than the other, and absolutely we should be doing that, because if something actually isn't providing value to the patient, or it's costing more, then we should at least have that information out in the system. But I think we need to look at it a lot more broadly. We would say we need to look at it, from the prevention perspective, from the screening perspective, the diagnostic testing perspective, treatment, follow-up, and even end of life. So it's a much broader view of comparative effectiveness and of evidence-based medicine, rather than just thinking about it from a drug perspective. I think a lot of people just drill right down, we're going to compare two drugs and figure out which drug is better. We need to think about it, I think, more broadly. There are limitations to comparative effectiveness research, and there are also, I think we need to be mindful of those limitations. Back to my point about, there's not always a clear-cut finding. And so you need to actually provide the evidence to the doctors and to the patients and use that evidence to make better decisions. And that's what the hope would be over time, and it's already been used in cancer in lots of different ways. But clearly there's a lot more work that needs to be done. And the other thing I think is important is people can't look at it as a silver bullet. It's not a panacea. I think a lot of people say, we're going to go off and do this, and suddenly everything's going to be perfect. First of all, it takes a lot of time to develop the evidence. Again, from a cancer perspective, right now there's a long-term trial going on in lung cancer. and on screening and the modalities of whether you should do CT scans or whether you shouldn't do, those types of evidence-based work take years, and then you have to interpret what that data looks like. So this is not something that happens overnight, but it's clearly something that we should continue to develop and work on and take a comprehensive view of it and really look at the long-term benefit. I don't think we should fear it. I just think we should have systems in place that actually set it up to provide both the ability for people to understand the limitations and also to make sure that we don't stifle innovation. We do look at, for example, from a cancer perspective, population-based studies to figure out, for example, who should get screened and at what age. And those are enormously helpful in figuring out kind of the appropriate level of care that people should be given. But at the same time, we know that if you get cancer, each individual patient is different. And even if 200 different kinds of cancer, each patient actually sometimes reacts differently to a specific same kind of cancer. They talked about Herceptin earlier. So knowing that you have a certain genetic makeup or you have a certain biomarker can make a difference in what kind of treatment you get at that point. But two different people will react differently. So knowing that information is extremely valuable, and we need to continue to develop it, but we shouldn't cut off the innovation piece.
Marc, if I could tee you up with essentially the same question phrased slightly different, because I want to get one piece of information out here. Phyllis mentioned the Institute of Medicine, which did issue its report on prioritization earlier. And they also defined comparative effectiveness. And as part of their definition, they say, the purpose of CER is to assist consumers, clinicians, purchasers, and policymakers to make informed decisions that will improve healthcare at both the individual and population levels. So there's recognition at the IOM, certainly, that this is important. So the question to you, Marc, how do we ensure that the purpose of CER does fulfill this vision that the IOM and all the people at this podium have laid out to make sure that the individual and population levels are respected?
Thank you, Dan. I think that's one of the critical challenges of this issue. When you look at CER, certainly from a patient perspective, we all want to have better information to make more informed decisions. And there are countless examples where there are multiple treatments with multiple different kinds of side effects. And there's that Hippocratic oath where it says do no harm. But if you're a patient, you're choosing amongst harms. You're deciding which harm is the best for you in your given circumstance. Look at somebody with prostate cancer. There are multiple different kinds of treatments, and yet most people with prostate cancer probably don't need any treatment at all, but we don't know who that is right now. Clearly, there's an opportunity for better research in this space. The challenge is the application. And as your question suggests, there are two different levels of application. There's the individual level and the population level. And I'll focus in on the individual level because that's really my area of expertise and give you three very specific challenges and then three potential solutions to these issues. First, and you've already heard this alluded to, we're very concerned about potential coverage and utilization applications of this issue. Now that's going to come from the policy level or the population level. The challenge with this, and it sort of harkens back to the question from the President, which really is which medicine should you take, especially if one is half price? Well, the answer to that question is it depends. Depends on the application. And the challenge with coverage and utilization policies, while they're important, if they're in a metric that is designed to promote value both to the patient and to population, to providers and payers, then it can work. But if the metric is simply to drive cost, it's a blunt instrument, and it doesn't address the application in the specific circumstances. And that's really the critical challenge from the patient perspective, and that is, how do you apply CER correctly at the point of care? How do you take that evidence that we've collected and bring it right into the point of care? We've never done a good job at that. We're getting better slowly, and there are some interesting and really creative tools that are working well. But the reality is your average patient is not coming into a delivery system where that is their reality. And as a result, we're not having great application of the evidence we've generated now. So I think we need to look at CER as part of the puzzle. Good CER and a good delivery model can facilitate good decision making. Without a good delivery model, the information doesn't help at the patient level. Even if you can get the best evidence into the point of care at the right time, getting the right medicine to the right person at the right time, you still have only met half of the equation. Here's where I think we've sort of missed the mark because we haven't really discussed this much. But the reality is you can give somebody best-in-class care, but if you've not done the comprehensive assessment to figure out what's going on in that individual's life, what is best in show, so to speak, in terms of care, may not work for that individual. Let me give you an example. You have a 50-year-old African-American woman who has heart disease, hypertension, high cholesterol. She's seeing multiple doctors on multiple medications. Fortunately, she's in a coordinated care system. She's getting what is best in class in terms of care. Challenge for this woman is that the medicine, the combination of medicines, makes her drowsy during the day. You might say, well, she's getting best in show, so to speak, for care, and that's great. But the reality is this woman's a bus driver. And if you haven't taken the time to figure that out, you've got a real challenge on your hands because she is not going to take the medicine. Or at least we hope she's not going to take the medicine. What you need to do is do the comprehensive assessment, combine that with the best evidence, and see what works for the individual. In her case, what might have been second best in class but didn't make her drowsy would have given her the care that she needed. So even with good CER, it's the application at the point of care that is really meaningful. The third challenge I'll put on the table, and it's been iterated as well, is the impact on R&D. People view the patient population as completely and totally absorbed in the access issue. And the reality is we do want access to care. We want access to all the treatments that are available now. But I can tell you what is equally important to the patient community is innovation. We're all concerned that our children and our grandchildren are going to have the same conditions we have, and we want to make sure that they have better treatments than we have. So we've always been conflicted with the challenge of access to what is available now, but also promoting better and new treatments for people with chronic conditions. Even if we do CER well, even if we apply it well at the point of care, with comprehensive assessments and get it right for the individual, it's going to have tremendous impact on the R&D decisions you all make. It already is. You're going to see products that are in the pipelines dropped because they're not going to fit into this new model. You're going to see new decisions made on where you go in the development of products. How do we solve these problems? I'm going to address 3 issues quickly, and some of them I think we'll come back to as we move along. First is, and this has been iterated as well, we need transparency and participation in the development, dissemination, and application of CER. And I underscore application because that's the piece that's been missing in the debate. We've not talked about how we apply this, other than to say you can't use it for cost determinations. The Senator Baucus's bill has done a lot in this space with respect to CMS, but I suggest that we can go further in several ways in this space. The second issue is that we've got to do better with HIT, both at the point of care in terms of delivering evidence into that interaction, which is only a few minutes between the patient and the doctor, but also in terms of doing comprehensive assessments. Much of this can be done electronically. There's some great new tools out there, but they're not widely utilized right now. Third, we need to look at the long-term value, not the short-term cost analysis. And I think this is critically important because we're so focused on cost right now. Congress has just invested billions, or is in the process of investing significant funds into this space. They're going to want results very quickly. This research is time-consuming. There's going to be tremendous pressure to show results in terms of cost on this. But the reality is, if we don't look at long-term value, we're going to have some challenges. And as the previous speaker, Billy Tozen, said, the reality is everybody's looking at medications, sort of the holy grail. Here's where we're going to save money. The reality is it's not the major cost driver in our healthcare system. It's the wrong thing to look at. Where we should be spending our time, where most of the money is wasted in under and overuse of care, is in the delivery of care. That's where there's an opportunity to compare systems and figure out what works well and what doesn't work. It's sort of like the story that everybody's heard. You have a police officer walking down the street at night, and there's somebody under a lamppost, and they're on their hands and knees, and the police officer asks, "What are you doing?" He says, "I'm searching for my keys." "Well, where'd you lose them?" "Well, over there." "Well, why are you under the lamppost?" "Well, there's no light over there." You know? We're looking at medications because that's the area we're comfortable with. But the low-hanging fruit is in the delivery system. So I'll stop there.
Well, I'll dive into one of the points that you raised, and Phyllis also raised the issue of innovation and research and development, and ensuring that we have a robust environment conducive to continuing research and development. I'd be interested in your views, Bob, on potential impact on innovation in a CER environment.
Well, I'm probably not going to be towing the line here. I do think that the model for innovation and R&D has to change, and should it is all about making the right business decisions and the right investments, and understanding, perhaps the reality of showing comparative effectiveness as well as cost effectiveness. That needs to be figured into the mix. And I do know that obviously in the pharmaceutical industry there's a greater kind of lead-up discovery period and early phase where there's much more uncertainty. Device is a little bit more certain. There's platforms that evolve as into different generations. But I do see this in some ways as a wake-up call, and I think in the end it's going to force the best companies to innovate within their innovation process. And the ones that will come up on top will figure out a better way to do it.
Phyllis or Dan, would you like to jump in on that topic?
I mean, I'd like to think that was correct. I guess my concern, obviously, is based on past history, and you know more from being in the business. But it's taken. Well, I don't know when the first hip and knee implant was developed. 50 years ago, 25 years ago, whatever. But it's just within about the last 2 years that we've had one specifically for women. And that's an example, I think, of investment in innovation in something that they could or could not have decided to do, depending upon what was going on in the outside world. And as I mentioned earlier, since we do lag behind in understanding some of the differences, sex differences as well as other differences, that it may influence decisions in terms of marketing. There's other examples in terms of, I know it's not all about drugs, but certain pharmaceuticals that have turned out to be more effective in women or less effective in women or whatever. And so I think, again, those of you who have worked in industry know, when they decide to go forward on something or not, and what the return's going to be. And so really the question is, again, the devil's in the details. Obviously, as I said in my final statement, we all want to know, we all hope that our physician is going to provide, what the best care is for us individually. But again, how this is going to be done and how it's going to be determined and what influence it's going to have on the marketplace and on industry, I think, remains to be seen. So the question is, how it's done.
Dan, did you want to comments on that?
I think maybe a slightly different point, but I think that we've got to go back and also think about one of the big questions is how are we going to prioritize what we're looking at. I mean, there are a million different questions out there to look at. And so if we take a macro view of what are the most important issues from a societal perspective to be looking at, that's something that's going to be difficult to come to some consensus on, although I think we should attempt to do that because we could follow lots of different leads. And I just think about cancer. There are just tons of different places you could go, and given the amount of time and the cost there is to doing this kind of research, it's very, very difficult to, you could spread yourself so thin that you wouldn't get done what you need to get done. So I think this issue of where are we going to focus as a country on this is very, very important. The other thing I think is, though, having said that, we also need to gather the resources that are already out there and put them in some kind of order. There is a lot of work that's being done in different places, and I think that one of the things that government sometimes can help provide is some kind of common platform where this information can be shared across varieties of sectors. And I think that's one of the places where we can hopefully move that forward from a policy perspective, because that's one of the things government actually can do well. Government doesn't necessarily do the research always well, but it can provide a place where you could actually set up feedback loops where this information is available in real time so that the doctors can actually figure out, looking longitudinally. For example, Bob talked about registries. Having more registries out there to actually see, for example, what is happening with the use of off-label drugs in cancer care. What are those outcomes that we're seeing, and actually getting to outcome-based results, and then looking across and saying, what are the patterns that are being evolving, but then interpreting them properly. This should not be a punitive system. In my view, it should be a system which is actually providing information that allows people to make good decisions, both the doctor and the patient, moving forward. And I think that's really kind of what we have to get to.
I'll just make one comment that more confirms your point, Bob, than is contrary, and that is, right now, pharmaceutical companies around the country and around the world are trying to figure out what the new model is going to be and how comparative effectiveness will be implemented and how it will be worked into their decision-making at an earlier phase. They're doing it in Europe, they're doing it in other countries as part of the regulatory schemes there, and it's just so those decisions are being made, those discussions are being held right now. Yeah, sure, Phyllis.
Just two other things. I just also I think with the emphasis and the hope for personalized medicine, obviously that's going to complicate things further. But I also do want to, what I should have said earlier, emphasize there are certainly certain treatments that we know work. When certain hospitals do better than other hospitals in terms of lowering infection rates and low-term, preterm birth rates and issues like that. There are a lot of things that we know already that are not disseminated throughout that need to be. And we also know that it takes years in some cases for translational research to actually hit the bedside with a lot of physicians and providers. So I don't want to point. Obviously, I don't want to be totally negative. I do think in those areas, comparative effectiveness and having a system where everybody is more up to date on the newest technologies and what works, generally speaking, or not, is a positive thing. Our concern, obviously, which I said, is that based on what kind of knowledge that's going to be, and if we don't know whether there are differences, sex differences, because we've never looked at them before, then it's going to be then it's not going to be beneficial for women. But I think, generally speaking, obviously there is a place for this. Again, as I said earlier, depending upon how it's done and on the basis of what kind of research.
Let me just add a couple of thoughts. I think Dr. Honigberg got it exactly right, but I'd like to add a patient nuance to it that I think is really important. There's no doubt that there is tremendous possibility in CER from the patient perspective. And I think there's no doubt that it increases the risk associated with the development of new treatments. The challenge is, how do we provide incentives to innovate in this new world? And I'll point out that CR is not the only risk that's being put forth. We're looking at a day and age where there's discussion about price controls, price negotiations, importation issues, CER. You look at your Medicaid rebate levels. There's a lot of issues that are changing the paradigm as to how you make decisions in terms of where you invest. All of that has impacts in terms of where patients get in terms of new treatments. And that's concerning to us. Having said that, the current incentives have largely been a free-for-all, quite honestly. That doesn't really help us either. You look at the patent system. People are surprised, at least in my community, to understand that there's nothing in the patent process that looks at the value to society for the medicines or treatments you're developing. That's a huge surprise to people with chronic conditions. And you know what? It makes them kind of upset. What I would suggest is we've got to look at innovation in a very different way. And I'll give you two very specific examples, but there are others. I think we've got to bring the models into this space that create the venture capital and other sources of income that come to play to develop the new treatments. But we need to do it in a slightly different way. We need to apply value into this space. Value to society, value to patients. You look at biomarkers, and I know there's been some discussion about that here and now. We wonder why we don't have as many biomarkers now as we'd like. I saw a recent study by PricewaterhouseCoopers that said most specialty products in the year 2020 will have accompanying biologic or biomarkers as diagnostics. And that's really great. And I look at the example just from my own personal experience. Both my parents have passed away. My father passed away of lung cancer. He was diagnosed at 58. At that time, he received the standard chemotherapy. He spent 18 months on it, and he died. Did nothing to improve his life. It did not extend his life. It diminished the quality of his life, and he died. We didn't know at the time that only 10% of the population responded to that. Now, there's been allusion to new trials that are looking, how do you figure that out? But the challenge in this space is the system is set up so we don't incentivize the development of these biomarkers as diagnostics. And we wonder why we have to wait until 2020. That's 11 years from now. From the patient perspective, that's way too long. You look at the uncertainties and the delay, the unanticipated costs, low or no reimbursement rates from CMS or the private sector, and quite frankly, it's going to reduce your market share. You're talking about narrowing the population you can sell your product to. Doesn't really work in our current framework, but there are solutions to that. We can work with the FDA to provide guidance on the approval process. We can look at coordination between centers. National Health Council is actually working on specific legislation that addresses this. We can look at the coverage issues. You know, CMS should be paying an appropriate amount of money for a diagnostic that tells you this is going to work for this person, it's not going to work for this other person. It is a waste of money not to pay for that diagnostic. That's criminal. We need to look at the business model. We need to have trials that are designed around the development of products with biomarkers as diagnostics. There are ways to make the process shorter and less expensive. We could tie it to expedited review of the products. There are multiple mechanisms we can use to speed up the development of biomarkers as diagnostics. We don't need to wait for this, folks. There are opportunities to develop or promote innovation within our current structures that provide really clear business models to companies, but also provide value to patients and societies. Look at the patent system. You know, I already referred to that, but the challenge is you're not going to develop a product with a weak patent or a product that is unpatentable. And when I start speaking with chief medical officers from the companies, from our patient groups, and from some of the academic centers, it's clear that there are as many small molecules that have potential merit as products that are not being developed because they have weak or no patents. That's criminal. We have folks from our patient advocacy organizations that have participated in clinical trials, and at some point down the road they found out that the product had a weak patent. They stopped developing it, even though it was promising for that condition. Some of these conditions have no viable treatments, period.
Dr. Honigberg wants to jump in on.
Yes, and you know, let me speak a little bit more specifically to the innovation I think we're going to see in industry. I think it's not only going to be in better investment decisions, it's going to be in a new development approach to development, using pharmacogenomics, using biomarkers to track response. Obviously, you have all the hurdles that are obvious with the FDA accepting the surrogate marker, et cetera. And then also, I think it's the companies that are most proactive about putting together a clinical development plan, you know, a package of evidence-based information that really addresses all of the key stakeholders in the market. And I think that is going to be the winning combination. I do want to make one comment on dealing with payers. I think an interesting model has been put forth over the last decade. It was introduced by Sean Tunis. It's coverage with evidence development. And I think there's been a very lukewarm response to that. And, you know, the ability to have payers pay immediately for a technology or a medication, but also collect data at the same time to understand if it works and where it works best, I think is a very logical approach. But there has been some pushback. So I also see a comeback of coverage with evidence development.
Let me see if there are any questions from the audience. So we'll see if we could get some questions, and then we'll wrap up. Yes, ma'am.
I have a certain sense of disassociation between most of what I've heard and what I see up there. The title says personalizing each patient. That to me means somebody is going to help me to navigate my way through all of the diverse providers and systems that are out there and find what is needed for me to put it on the IT system so other people can share it and so forth, so that I am dealt with as a whole person with multiple whatever. The second is I look up, it says Aspen Health Forum, and I've been on the internet looking at that and looking at their stewardship idea, and I think that is the greatest thing since sliced bread. Now that is way far in the future. It's something that people are going to have to spend a lot of time going toward. But it seems to me that the Congress has been talking most about health insurance and not what's out there and what will evolve out there that this insurance might finance. It's a great first step to talk about covering more people. Fine. What I'm hearing from most of you is how would we more carefully evaluate the provider system we have now? And one of the things about the stewardship idea that I really like is that formal education and formal evaluation is only part of the way you learn. A lot of the way you learn is by getting a team of people who are trying to work toward the same goal to evolve their work and share that informal knowledge with each other. And that, I think, is what the stewardship idea is moving toward. And where I come from, with respect to what's on the Hill for the moment, is that I like the federal health benefits program because one could have at the federal level some basic understanding of the finances of the insurance company and the basic plan that it should provide and so forth. One could have a new bid to be incorporated in that exchange each year or each 2 or 3 years, so that could evolve gradually. One could have a state or regional component of it, so that for insurance you could have it nationwide, but at the same time you could make room for networks of providers and HMOs that only apply to a certain small area. And I don't hear any of that from this panel, and I don't know why I should fix on you, except for the title right there, and I was just sort of waiting for that. That's what I came to the conference for. And so I'd like to hear some response or thoughts about that.
Well,
So, go ahead, Phyllis.
okay. Well, our charge was comparative effectiveness. So the title perhaps was not perfect, but our charge was really looking at comparative effectiveness in terms of the individual patient. I don't disagree with everything else you said. I call it integrated care. I think you're saying stewardship. It's pretty much the same thing. And I agree that the Congress, and this is my personal opinion, that the Congress is focused more on health insurance reform than health care reform. And I think it's Wyden's bill really is close to the FHPB. So I don't disagree, and that's, I guess, a charge for another panel or another conference. But that was not our charge, so that's why we didn't address it.
Just to pick up a couple things you said, though, I think one of the things as we look at healthcare reform, and from the American Cancer Society Cancer Action Network perspective, we've been focused very broadly on health reform, and it's been a top priority for us. And so patient protections is obviously very important, and having information about your insurance options, like you talk about with the federal, the FEHBP system, which I used to be part of when I was a federal employee, and it's a great system, and you can figure out kind of what your choices are and what you're getting, and it's all kind of in front of you versus, having some choice is really important. But I think something you said that was really important, and I think this is where we need to get to, is we need to get to a system where patients and doctors are sitting down together and figuring out what their goals and objectives are before we jump to tactics. Right. I think what happens far too often in the medical system is someone comes in with a problem, and because there's not enough time to actually sit down and address, okay, well, what's your goal? And let me just give you a very specific example in cancer. If you're diagnosed, Marc talked about his father, if you're diagnosed with lung cancer, your chances of survival are not great because we don't have great treatment for lung cancer. We just have to be very honest about that. There are things you can do, and certainly as a patient, if you want to try those things, you should try them and go through that system. But someone should sit down and talk about what your goals are as a patient and work through those goals very directly. And then you can go to tactics and figure out, okay, based on my goals, this is what I want. And that goes from everything from something that's highly curable, like breast cancer. Okay, my goal is to blank, but here's all the side effects. Here's the things that we're doing. And I think that happens in the system, but it happens more episodically rather than more system-wide. And another example of that is end-of-life care. There was this huge blow-up about, whether Medicare was going to reimburse for the doctor to sit down with the patient to talk about their options at end of life. And people claimed those were death panels. Well, from our perspective, those conversations absolutely need to occur, because then you're providing appropriate care for folks and you're actually improving quality of life. And again, it's not to deny care or not to actually pursue aggressive care. Every patient's going to make a different decision based on their life experience, where they are in their life. If I'm a young father and I want, X many more years, I might be much more aggressive in what I'm doing. But if I'm in a different situation, I might say, hey, enough. I'm good with that. So I think focusing on goals and objectives is somewhere where we need to get as a society, and that requires responsible conversations, which frankly, maybe are not happening at this point, and we need to actually think about that. The last point I'll make is one that we've been emphasizing, which we're excited about in the system reform places, but on preventive care and early detection of disease. We have a sick care system in this country. We don't have a health care system in this country. We treat people who get sick with disease, and we run them through a system that we've set up to respond to that. That system makes sense because we used to not understand much about prevention. We know a lot more about it now. We need to turn the system on its head and really focus on prevention-based strategies, on early detection-based strategies. We know, for example, in cancer, this will, I think, probably shock a lot of people, 60% of cancer deaths could be prevented with stopping smoking and having appropriate weight control. Those two elements alone are responsible for up to 60% of cancer deaths. And then if you add colorectal screening and then early detection of breast cancer, those are huge gains you can make in the medical system that do not require new science, don't require a lot of new thinking. It's just applying it to the system. So maybe that gets a little bit more to what you were thinking about when you came to the conference.
One quick comment from Dr. Honigberg, then a question, and then we'll wrap.
And I want to make this comment because I'm a task force member for the stewardship project. And, 2 years ago, the prediction was that this would become more of a health insurance reform. And one of the founding principles out of the 10 principles is that stewardship it's more than about access. But it has become very much of an insurance reform type of legislation. I think, the intersection here with this panel is that the stewardship also embraces the philosophies of transparency and choice and patients and all the stakeholders taking responsibility, accountability. So comparative effectiveness is just another way of generating information and data that should be shared in a very transparent way. Obviously, it's imperfect in that you're never going to have all of the clinical data. It never will clinical decision-making be so straightforward, and where you don't have conflicting results, and where expert opinion, which actually is actually an important part of guidelines. There are very few guidelines just based upon clinical data. There's expert opinion using various techniques.
One last question, and I would ask the panelists to respond quickly.
Hi, my name is Chi-Onye. I'm a researcher at Children's National Medical Center. I have a little bit more of a comment, and maybe you can comment on my comment. But I'm in talking about personalized medicine and innovation. I was really happy to hear about the need, or the emphasis on diversity, whether women, minorities, or just groups that are often forgotten in research. But I run a metabolic syndrome study partnering with Howard University. So we actually enroll healthy individuals that are African American in general. Primarily females have been enrolled in this study looking for genetic risk factors for metabolic syndrome and type 2 diabetes or obesity. And so I wanted to emphasize the need for innovation to stretch to younger generations and not just at the patient level. This group of individuals that I work with are young adults, which is often a missed group, missed because they either fall off of their parents' insurance at some point, they're missed because they're not really talked about as being unhealthy, or they're just missed because they don't get comprehensive care. When they do go to the doctor, they're just assumed to be healthy. And so we sit down, and as part of the study, we provide back results of the things that we've tested. So we've done like blood labs. And for the first time, these students are hearing why it's important to check glucose, lipids, and insulin. These are things that they don't get spoken to. They just get told all your labs are good, and they move on. And so they are actually like the children of the 50-year-old woman that you described who has a condition or disease and is suffering from a chronic disease, and her children are watching it, and they might be affected. Some of them know they have diabetes in their family. They just don't know what to do. So I just think that it's important to stress that this innovation and concept of personalized medicine goes, when you're talking about a group of individuals like minorities who suffer or have an increased risk for certain diseases that are affecting our population at a increased rate, that we expand this concept of personalized medicine to individuals that are affected directly but not necessarily symptomatic at this point, but have the potential to be the disease population 10 years down the road.
I think that is right on target, and it speaks to the issue of aligning value into the innovation paradigm, and it's something we've not done well. But I go back to the issue of patents and not having a connection to what is of value. But you can imagine a framework where we provide regulatory exclusivity. And this is not a novel concept. We do it with the first generic to come to market, gets 180 days exclusivity. And that creates great incentive to be the first company to be there. We can apply that concept to replicate the patent system for products that are not patentable. But what you do is you tie in two values. One, the cost of developing the product, the time to get it approved at the FDA, which will vary, but then also align it with social values. So you can imagine a product that treats a rare disorder, a product that treats pediatrics, a product that treats a neurologic condition that we don't have a good treatment like Alzheimer's, or products that treat minority communities. You look at heart disease and diabetes. Why are we not getting the same outcomes with the same treatments? You could add exclusivity periods for products that are aligned with the values that we could establish. That's something that's missing in the current paradigm, and I think we can add that in certain ways. And that's what I say we need to look at this through a patient lens with a different nuance and bring value into the discussion, but create and sustain a business model for companies to do this.
I think what you've described is what I like to call a predict and prevent type of model, where you've identified high-risk individuals, in this case through genetic screening and also looking for various high-risk symptoms and elements of disease. So there's a risk stratification aspect. And then you've increased surveillance. This group is now being followed very closely. And hopefully it'll allow early intervention and even potentially prevention of some of the severe comorbidities that go along with metabolic syndrome. So I think it's a great model. I think a lot of innovation, device, diagnostic, IT, even pharmaceutical, I think it all fits very well into an approach like that.
And I'll use the question just to make a shameless plug for a conference that we have coming up in 2 weeks, which is on the intersection of comparative effectiveness and personalized medicine, a full-day conference on that very topic that we've hit on tonight. And if you want more details on that, I'm happy to talk to you after. But I'm going to wrap up and just say I think during the course of the conversation about comparative effectiveness, I heard some consensus on the panel, a rough consensus that I would say is maybe a revised version of an old axiom. Maybe it's a perversion of an old axiom, trust but verify. We support the concepts of comparative effectiveness. It can do good and help clinical decision making, but capital B, we must be vigilant that the individual is looked out for and protected along the way, and that for it to truly reach its promise. So with that, I will close and thank everybody and thank the panelists.
And I ask you to join me in thanking the panel for a wonderful contribution.